we have already heard exhaustively on how we manage squamous cell carcinoma, that too with a single TKI, where we don't have targeted therapies in squamous and we have a TKI which has an evidence in squamous cell carcinoma. So now I will be speaking on sequencing of EGFR TKIs in management of non-small cell lung cancer. So we know that we have first, second, and third generation TKIs, and all have got approval in the first line setting. So whether to use first followed by third, second followed by third, or its third generation upfront is what we will discuss in these following slides. So when a patient of EGFR mutant lung cancer comes and sits in front of me in the clinic, I will decide which TKI I have to select based upon these factors. I will think what is the efficacy, what is the probable PFS, and what is the overall survival when I give this TKI efficacy. And secondly, when this patient progresses in second line, will I be able to offer another TKI, or should I go for chemotherapy in the subsequent line? Because we know that immunotherapy doesn't work in this setting. So I'm more focused on the subsequent treatments, acquired resistance, and brain mets. So all these are the factors which I will think in the clinic before I put my pen on the paper to prescribe the best TKI or the TKI combination for these patients. So these are the differences between the first, second, and third generation TKIs. So the first generation TKIs, we have erlotinib and geftinib. We know they are reversible EGFR inhibition, number one. Number two, they also have some inhibition on the wild type EGFR. So they are not broad spectrum. They have some wild type EGFR activity, and they are reversible. So, and they are not active on T790M. Afatinib and tocometinib are the second generation TKIs. We call these as pan-ERBB blockers. They're also effective in HER2 mutation, so they are pan-ERBB blockers, and they are irreversible in the cause covalent binding. So they have a very broad action, and they don't have a great T790M activity. The MIC required for anti-T790M is quite high for second generation TKIs. So if you have a rare mutation on those situations, second generation TKIs, especially afatinib, has a very good evidence for treating rare mutations like exon 18 or exon 20 non-T790M mutations. So irreversible and broad spectrum. Also has wild type anti-EGFR activity. And then osimertinib is the third generation, which is specifically designed to inhibit three things. One is T790M, exon 19, and exon 21. So it's excellent for T790M and exon 19, but exon 21 is not as strong as a second generation TKI probably, but we don't have head-to-head, but this is what evidence we have. So it is a very strong T790M, very strong exon 19, but a weaker exon 21 when compared to a second generation TKI. So how do I select which TKI I have to offer for a patient? So this is an excellent depiction of the heterogeneous cells we have. You can look into the cells, the light color cells, the lavender color cells with a purple dot within. There are the ones which are sensitive cells, the deletion 19 and exon 21 mutant sensitive cells. And then you have those yellow ones which are there in the first leftmost. They are the T790 mutated cells, and the dark brown ones are the compound mutated cells. So the upper row is what if I give a first generation TKI. So first generation TKI is a reversible inhibitor of exon 19 and exon 21. So you can see these light lavender colored squares getting less in number. You are seeing some T790M, but you are also seeing these compound mutations popping up and also some minor mutations popping up. And then, mind you, these brown colors are compound mutations, or these minor mutations don't have a targetable drug. So we must always try and select out these yellow squares so that they become sensitive to osimertinib. So if I use a second generation TKIs, it has a pan ARBB activity, and you can see that the predominant resistance mechanism, if I use a second generation TKI, is T790M, because the other minor mutations or the compound mutations are actually taken care of by second generation TKIs. So when I'm using a second generation TKI in the frontline setting, Fartinib or Decomatinib, uh, I am trying to inhibit all the clones of cells except T790M. So T790M becomes the predominant resistance mechanism if I am using a second generation TKI, and therefore it is better, and I can put a third generation TKI in the subsequent line. So to say in simple words, if I use a second generation TKI in comparison to a first generation TKI, I'm trying to induce a T790M induced resistance. And hypothetically, the third generation TKI will have a better PFS2 when compared to the PFS2 of a first generation TKI, because we are getting these yellow squares that are basically T790M mutant, and they're sensitive to osimertinib. So this is what is clonal selection of T790M positive cells if I am using a second generation TKI in the frontline setting. So these are the molecular mechanisms of acquired resistance to first and second generation EGFR TKIs. So you can see that nearly 50 to 70% develop a T790M mutation or first or second generation TKI. The likelihood of T790M is 1.5-fold higher in exon 19 deletion compared to L858R. Patients with deletion 19 disease have a likelihood to acquire T790M in 75% patients. So in the previous slides, pictorically, we understood that if I'm using a second generation TKI, I am selecting out more T790M. Similarly, exon 19, if I am targeting, whether it's first or second generation, the T790M development is in nearly 75% patients. And therefore, this exon 19 does well, has an excellent PFS1, also will have a good PFS2 because the predominant resistance mechanism is T790M, and which is targetable with osimertinib. You can see the other mechanisms of mutation. You can see in books we have T790M being present in 60% patients, which is targetable. The other 5% do have T790M. It is with MET, and the other one is with small cell transformation. And you see this small cell transformation in 1%, and then small cell with MET in another 1%, and MET amplification another 3%, and HER2 being there in another 8%. And HER2 T790M is another 4%. So you can see this compound or mutations when you see a combination of mutations being there if I'm using a first generation or a second generation TKI in the frontline setting. So by rule of thumb, 60% of them develop T790M. If I'm using a second generation TKI in the frontline, I will be probably getting a higher percentage of T790M. And if I'm targeting exon 19 patients, then again, the evidence is there is a 75% chance that the patient will have T790M in the subsequent line. So this is the molecular mechanisms of acquired resistance to first-line osimertinib. So we know osimertinib was originally designed for anti-T790M activity, but later on we have a first-line approval in FLORA where we have excellent exon 19 and a good exon 21 activity, and has shown one of the best PFS, and of course translating into overall survival also in spite of crossover. But if you look into the subsequent therapies, you can see a big chunk is unknown, and the rest all, the most frequent resistance mechanism was MET amplification. So mind you, MET amplification is not as targetable as an exon skipping mutation. And EGFR C797S in another 7%. And additional studies have shown that a frequency of histologic transformation after resistant osimertinib was nearly 14%. So if a patient progresses on osimertinib, he having another driver mutation or a targetable mutation is very unlikely. So the patient will probably go in for chemotherapy only. So most of the acquired resistance following first line osimertinib is not targetable. So therefore, we cannot have a long chemo-free interval if I am using the osimertinib in the frontline setting. So this is excellent depiction. You can see the columns, the 4 columns are there, or 4 bar diagrams are there. You can see if I am using osimertinib in the frontline setting, then in the subsequent the first subsequent therapy is 68% times it is chemotherapy. So if I'm using osimertinib frontline, subsequent line 68% chance that the patient will receive chemotherapy. Similarly, if I use a comparator EGFR TKI in the front line, first or second generation, or a first generation TKI in this, so the patient receiving subsequent osimertinib is nearly 47%. So basically, if I'm using osimertinib in the front line, there's a high chance that the patient will have to receive only chemotherapy in subsequent line. Whereas if I'm using a first generation TKI, then the chance that the patient will have another targetable mutation and will have a chemo-free interval is higher. So again, you can see here the similar depiction. First generation TKI, T790M positive. I can put another osimertinib and can give a longer PFS, a chemo-free PFS. Whereas if I use osimertinib in the front line, ultimately the subsequent treatment what I can give is only chemotherapy, because it's hard to get another targetable mutation in the subsequent line. So to just say all that, we have this excellent real world data, that is afatinib followed by osimertinib in the real world setting. So this is basically the efficacy of sequential treatment. So what if we can combine the best second generation TKI afatinib followed by osimertinib? What is the PFS in different subgroups? What are the response rates? What is the overall survival in different subgroups? Which what we will understand from this Geotag study. So it's a global observational study across 10 countries. The aim is to assess the total treatment duration of sequential afatinib in patients with EGFR mutant non-small cell lung cancer with T790M acquired resistance in real-world practice. The eligible patients were EGFR mutant non-small cell lung cancer. They had common deletion 19 or L858R mutation. They were TKI naive advanced non-small cell lung cancer, and age is more than 18, and the PS was 0 to 3. So they included even PS3 also. So they were initially treated with first-line afatinib. Upon progression, patient who developed T790M mutation received second-line osimertinib. This is standard of care. So the primary objective was to determine time on treatment of afatinib as first-line therapy in EGFR mutation positive lung cancer, followed by osimertinib in patients developing T790M resistance mutation in real-world setting. The secondary objectives was to determine the updated time on treatment in various subgroups and to determine overall survival in various subgroups. So this is a study design. So you give afatinib in first line, and then T790M mutation was seen. In those patients, you gave osimertinib. And patients must have initiated osimertinib 10 months prior to data collection. At least 10 months of osimertinib should have been there in these patients. So what was the measures to reduce selection bias? Only consecutive patients fulfilling all inclusion criteria were included. Enrollment was limited to 15 patients per site, not more than that. Patients with baseline brain mets and ECOG up to 2 was included. Even we could see the inclusion criteria having 3 also were included. and no cutoff on minimum duration of afatinib use and osimertinib use. So there was no cutoff duration that was there. So what are the advantages of real world data? So we cannot match a real world evidence cannot be matched to a clinical trial, but real world evidence sometimes include certain patients who often get excluded in clinical trial. Similarly, Geotag study included broader range of patients, no age limit. More than 65 years was 35% patients. No restrictions on initial dose of patients. 1/6 of patients initiated with afatinib, which we usually do in real world practice of less than 40 milligrams per day, and included patients with the ECOG performance status of up to 2 or more in nearly 15%. And there was no control over lower compliance, polypharmacy, or loss to follow. So all these real world advantages are highlighted in this. So what were the results of the Geotag study? The time on treatment with afatinib and osimertinib. You can see the start of afatinib in 2017, 16, 15, and this is the time on months, and you can see the start of osimertinib. So they included at least, they should have been on 10 months on osimertinib, and the median time on treatment of afatinib was 11.9 months, very similar to the Lux Lung studies. And this is the PFS we had in Lux Lung 3, 6, and 7. Median time on treatment and the PFS was around 11.9 months. So this is the time on treatment for the sequence of afatinib followed by osimertinib in the whole population. You can see the median time on treatment is 27.7 months, which is phenomenal. It is crossing 2 years. Similarly, the time on treatment for afatinib followed by osimertinib in deletion 19 subgroup is 30 months. This is time on treatment. In Asian patients, it is more impressive. It is 37.1 months, crossing 3-year mark. Similarly, in older age patients or younger age, it doesn't have much difference, 28.7 versus 27.3. And in those patients with and without brain mets, even in this situation, afatinib followed by osimertinib had impressive time on treatment. And these are the overall survival data. You can see 37.6 months is the median overall survival, which is in par with that of the Flora data. So the median OS more than 3 years, that is 37.6 months in overall population. The 2-year probability was 80%. So staggering numbers if you can use afatinib in first line and then osimertinib, and these are the numbers you have. So overall survival patients in ECOG 0-1 versus 2 or bad, that was 15% patients. This is 41 versus 32. And then this is the overall survival in deletion 19 patients, 41.6 months. So it's nearing 3.5 years now. And then median overall survival in Asian patients is 44.8 and 90% median overall survival at 2 years with afatinib followed by osimertinib. So these are the summary of results. Overall time on treatment was 27.7, and then exon 21.19, brain mets 22.2, ECOG PS2 22.2, without brain mets 28, and deletion 19 and ECOG 1 was 30 months, and in Asians it is much better. Asian with deletion 19, the time on treatment is 40 months. And these are the overall survival. You can see the overall survival. Asian deletion 19 is 45 months if I can use afatinib followed by osimertinib. It's nearly 4 years. It's reaching 4 years of overall survival if we can use afatinib followed by osimertinib. So, which is a better TKI prior to osimertinib? Is it a first generation TKI or a second generation TKI? This is another excellent study. It is a retrospective multi-center single country study comparing the responses of osimertinib in 2 groups. Group 1 was first generation TKI followed by osimertinib, And in group 2, it was afatinib followed by osimertinib. The study compares the response to osimertinib in second line in group 1 and group 2. So you can see the response rates of osimertinib post first generation TKIs was 53 versus 82%, which was statistically significant. The disease control rate was also statistically significant, and less progressive disease and better partial responses. So this is just reflecting the idea that if I can use a second generation TKI, I am just selecting out patients who have a higher T790M and they are more sensitive to osimertinib in the subsequent line setting. And that's the reason why you are seeing improved response rates with osimertinib. If I'm using osimertinib post afatinib versus using osimertinib post first generation, you can see the difference, a statistically significant difference in response rate and disease control rate. And this is the progression-free survival with osimertinib. This is basically PFS2. If I'm using first generation TKI, you can see the PFS is 9.7 versus if I've used afatinib in the front line, just because we have selected out patients who had T790M, the PFS is 17 months. So this is another one original study, the first versus second generation TKIs, real world evidence, population based single center retrospective review of patients with EGFR mutated non-small cell lung cancer who were initially treated with first or second generation TKI. So first or second generation TKI, you can see the entire cohort, afatinib, the overall survival in months was 39 months versus 25 months. Exon 19 was 48.8 months, crossed 4-year mark versus 26 months. And uncommon EGFR, again, you can see 48.5 versus 32.7. And exon 21 was 25 versus 20. So only 53 patients, 7 patients in afatinib and 46 patients in first generation arm received osimertinib. So you can see staggering differences in overall survival if you can use afatinib in frontline setting. So there were other studies. You can see an observational study from French nationwide claims and hospitalization database. Non-small cell lung cancer patients receiving osimertinib following first or second generation TKI. Median time on treatment was 34 months. Overall survival was 37 months. Another observational study from Japan. Overall survival in patients who received osimertinib following afatinib was 49.6 months. In contrast, the OS among patients who did not receive osimertinib following afatinib was 33.8 months. So what is the importance of sequencing and concept of chemo-free period? So if I'm using osimertinib frontline, I get a PFS of 18.9 months. And then subsequently, we don't get any targetable mutations because we have already exhausted T790M and other sensitive mutations, and resulting mutations are not targetable. Therefore, subsequently, we are left only with chemo and best supportive care. And you can get a maximum of around another 18 months or so, total of 38.6 months the overall survival. So this included only PS0 and 1. So if you look into afatinib followed by osimertinib, you can see the PFS. The PFS is longer. And if I can use subsequent therapy later, chemo or best supportive care, which is post-afatinib progression, this did include ECOG PS2 or more. So in this subset of patients, we had a longer overall survival. So afatinib, osimertinib, in comparison to osimertinib frontline, you can see how the overall survival is longer if we can use a sequencing rather than using a third generation TKI upfront. So the time on treatment, PFS1 plus PFS2, and the overall survival, chemo-free interval, all these are better if I can use afatinib followed by osimertinib rather than using a third generation TKI in the frontline setting. So putting overall survival into context, first generation TKIs, the overall survival is around 2 years. First generation TKIs, if we can use proper osimertinib, 32 months, something around 2.5 years. Then if I use afatinib, with limited osimertinib, it's crossing 3 years. Decomatinib is nearing 3 years, and osimertinib, it's around it's crossing 3 years again, 39 months. If I can use a proper sequencing, then we can see an upper limit of overall survival, nearly 46 months, which is crossing, which is nearing up to 4 years. So the combinations are there. We have Geftinib plus chemotherapy in Japanese data, 52 months, Erlo-Pave 47 months, and Erlo-Ram is immature as per the RELAY trial as of now. So the take-home messages are: we should not exhaust our TKIs using them in the frontline setting, so that for subsequent lines we are not left with any other targetable mutation and we end up giving chemotherapy. So this will result in a good PFS1, but the subsequent PFS2 becomes shorter and the chemo-free interval is not longer. So if I can use a second generation TKI like afatinib in the frontline setting, I can have a reasonably good PFS1 of nearly 1 year, and then I can select out patients who have nearly some 75% chance that the patient will have a T790M mutation in subsequent line setting. And if we can use osimertinib in subsequent line, the PFS2 is longer, the chemo-free period is longer, and this results in a longer overall survival. So moreover, we also have an excellent Asian data and also very good data in exon 19 subset. So if you have an Asian exon 19, I think we shouldn't miss. We should be using afatinib followed by osimertinib, because this has given us the best results where we have seen overall survival crossing 4 years. So with this, I would thank everyone for their patient listening. And Dr. Niranjan, back to you.
Thank you, sir. That was